So just to kind of tell you like the gravity and the magnitude of what we have going, everybody knows that our mission, and I'm in the Army by the way, is to go to war. We're by Congress, we're supposed to have a readily deployable force. And the Chief of Staff of the Army basically has says, readiness is a very key priority. It is a top 3 priorities. So I'm in the William Beaumont market in El Paso, Texas. What's unique about us is that our care spans 2 states, New Mexico, Texas. We have the largest Department of the Army training facility, over 1 million acres. Our patients can be anywhere in those 100 million acres for care, just to see how large it is in perspective. Several facilities in our market. We have a community base out in the city of El Paso. We're about to get our 2nd community base, plus several outlying clinics, plus 20 other facilities on the forklift installation that focus on anything from the Integrated Disability Evaluation Systems, IDES, which works with the VA, the Soldier Readiness Center, and I'll talk about that briefly. But 73,000 enrollees in our market, enrolled to us, and there are about 100,000 out there that we do provide some type of tertiary special trauma care. And we still, although the Army is downsizing, we still have a remaining warrior transition unit. Very much small, but because we're our mobilization platform, we have a WTB that will stay. What's interesting about us is that Fort Bliss was really, honestly, when I was a Baylor resident, I trained here, it was kind of a dud. It was going away, very small populations. If you can see back in 2005, we only had about 10,000 soldiers. Now, 2013, after BRAC, we're at 27,000 soldiers. Population grew almost overnight. We went from being a training unit to being a mobilization platform, supporting 13 of the brigades in the 1st Armored Division. So we went from just being basically a place of providing education from Sergeant Major's Academy in the Air Defense to being a place where people go to war every day, are in places of conflict, and they need to be able to go there and be able to, of course, be deployable. This is the leadership. What's interesting about this is we're going through a paradigm shift as an organization right now. We had to reset in January. There's this thing called the HELOS, the Healthcare Executive Leadership Organizational Structure. We had to stop basically what we were doing come January, reset everything about our business, and organize ourselves. I put X's over everything we didn't have before 1 January, and now we have, we used to just have DCCSs, which is basically your senior medical person. We had a senior nurse and a senior administrator. And now we have, where all those X's are, we have this new infrastructure with new missions. So in an environment where we're focusing on readiness, you've probably heard of the MHS review in 2014 that came out with Secretary Hagel that didn't say we were doing very well compared to our peers. We're going through this transformation, and we're working through it. Some of the things that we're now having to deal with as a new variable in this process is, although we're still focusing on readiness, we had to make some tweaks. So I guess you're saying we're going rogue, and this is part of the best business practice that goes along with it. IDES, that's the Integrated Disability Evaluation System. So if you really, really get broke and cannot necessarily perform your mission anymore to go to war, you will eventually go through there, be evaluated, and turned over to the VA. And this operation and readiness. We are switching that. We've put an exceptional policy in to say that this is more in line with what we do in our mission because we are a mobilization platform. We have about 50,000 encounters that we do through our SRP that not only contract employees, soldiers, individually deploying soldiers, and units that come through Fort Bliss, Texas. So for us, we thought that it would make more sense, and we were waiting on our hires to say if you, mother may I, yes you may or not. But we thought that it would be better if IDES was over where the health and readiness commander is, and operations is back where it has been for its infancy under the DCA. So with that being said, With all of the changes with the 1st Army Division coming on, we've been doing things now for well over 2 years now. We first started by hiring case managers. Before we really established a primary care service line and the Soldier Center service line or medical home service line, we said, you know what, we need some nurse case managers and some LVNs to start looking at this readiness to make sure we're keeping our soldiers readily deployable. So we did that. We put them basically once a month. We started this thing called an evaluation board, a physical evaluations board, where we sat down with the division surgeons of the units, the senior medical people, and that leadership, and we'd go over all 200, 300 people who are medically at risk and say, okay, here are the people we believe we'll get back to your unit so you can deploy with them, and these are the people we think need to go into this IDES system because we don't think they're going to be returned to health. And then we facilitate their care to get them one or the other, get them back to health and get them out the system. After that, we said, you know what, that's not enough. Part 2 was to put those people in the primary care clinics so that they could be where the care is being provided. And so we put those case managers and care coordinators in the clinics. They are part of the team huddles that happen every day. Anytime a soldier comes through the door, we have already looked at them 72 hours out to see if they have any readiness that's required for them, immunizations or anything to that effect. If they've done their post-deployment physicals, we schedule those things before they come. And then when it's all said and done, we go find them. So they're a part of the team. We will actually have our teams leave our fixed facility and go walk amongst the units to work with their senior medical people so we can get their people cared for. That is working very well. It was working well enough that MACOM wanted our team to sit on the demo project for the new COAs, or courses of action, for the medical management centers as they're developing new processes. So our team has been on that now for over 18 months. New policies have been coming out. They were very integral in what we call the medical readiness transformation. This is actually started 1 June, where we are changing the way you evaluate people who are medically at risk. And so basically, you could be injured for years and years and years, and the only thing you have to do is just go get another piece of paper that says, I can't go anywhere. Or you can have teams proactively looking and seeing how injured you are and either get you to a place of health or get you out the door. There are probably 15-20% of the Army in the past decade that were not deployable. So anytime we had to deploy a unit to go to Afghanistan or go to Iraq, we'd always have to have them plussed up in the HR world because everybody couldn't go. And so what we're doing now, part 3 of that, is now that this helos has happened, and we feel that it's a good thing at a medical center, the public health is now part of the medical team. And so now we have our public health nurses using a new tool that came out in the last 12 months called the Medical Readiness Assessment Tool. So like pop health management, like you do with the disease management, we're now taking this as a practice, or we're doing that for readiness management. If you've had a history of certain types of injuries, we have our case managers now looking and going back to your leadership and saying, I think that using this predictive tool that I think was developed by some high-speed Baylor person, actually, I've run across. But this tool that was developed using a lot of binary information and tools in a cloud, they have decided they're basically going to determine who those health risks are, get those people identified, looking at the missions that we have going, what type of unit you're assigned to, if you sit at a desk, if you're carrying 25, 30 pounds, let the command team determine if they could be returned back to health to perform the mission, and if they're not, get them fit for duty and get them evaluated and get them out where they need to be better taken care of because they're not necessarily, in this case, value added to the unit. So working with the command team and working with the provider, we're actually far more proactive now in managing readiness. All of this, I think, being attributed to some of the realignments that are happening with helos, giving a lot of restructure to what we're doing. But with this, we know we anticipate another 3,500 soldiers in the next 8 to 12 months that will be coming through because the model says that's what we're expecting above what we have had historically to be broke. We will be using that to try to make sure we're resourced, we don't get bottlenecked. We definitely don't want to be in the news because we're not taking care of our wounded warriors and our soldiers. And so it's been a 3-step process, but this proactive look at health readiness, I think it will help us not be in the news as much and show that we're doing everything we can do to get the soldiers through the process quickly enough to get them their entitlements and get them onto a better quality of life. So that's all I have, unless you have questions.
Any questions?
The public health nurses, so your case management, is anyone helping them transition to the VA? Like, if they have to go to that point, is there?
It doesn't happen at the public health portion of the model, but in the IDES world, yes, it does. You have a patient you have the medical evaluation, you have the patient evaluation, and then you have the transition to the VA, and it's all integrated into should be less than 180-day window when they're identified if they cannot be returned to health. And so we look at those numbers and every milestone on where they are in those 180-day count, and it's going to drop down for us to 160 days because of the partnership with the VA. But yes, step by step by step.
Sarika, actually your last statement is a good segue to my question. El Paso, and William Beaumont specifically, is unique and on a cutting edge in that it had a contiguous VA. You all were in
right.
kind of the same building. Where is that relationship now with the new facility that's being built out there?
Mm-hmm.
And can you just speak about the VA DoD kind of relationship?
Absolutely.
Nothing specific, but this.
We were supposed to be in our new facility, originally dated 1 April of 2016, so that would have been a few months ago. We will actually not even occupy the building until October of 2018, with first patients coming in June of 2019. So we're a little behind and over budget with the contract, to say the least. With that partnership, the VA is co-located with us. We actually share surgical suites. We have the ability on the 4th floor to walk from the VA's OR ambulatory suites into our OR. We are discussing right now if we can continue to have some outpatient ambulatory surgical seats to support the VA from a convenience. We don't know because it's an old building and it costs a lot to keep that portion of the Army's facility running. So we'll work on that. There is a platform, though, in the new hospital footprint if ever the hires up decide to put the VA next to. It's already, the foundation is there. We're going to use it as a running track until the funding becomes available. But we do anticipate that happening one day before my kids die. No.
That's amazing.
Yes. Anybody else? Yes, sir.
Are you seeing any restriction on the VA partnership with the DoD's decision not to become a choice provider?
No. Well, not yet. I don't know what the future lies, but I haven't heard anything or any rumors. And we have a very, very active Congressman O'Rourke, and I haven't gotten anything as yet. But if it's coming, we'll hear through the congressional lanes before we hear anywhere else.
Yeah, we just, at Eisenhower, we're in a situation where one of the 3 VAs that we partner with has decided not to continue sending us referrals because their purchase care, what we would say their purchase care dollars have run out and we aren't a choice provider.
No, we have an MOU right now. We have a VA liaison, and our costs are 10% below the Champus rates, or CMAC rates, which is, they're a bargain for them to come to us, and so we just do that to keep our GME programs where they need to be, and so it's kind of a win-win by this MOU agreement, and so that is working for us. Our biggest threat is that Congressman O'Rourke wants to bring in a VA hospital in El Paso, and that may be an issue if we cannot get the levels of acuity that we need for our GME programs. So.
Thank you, ma'am, very much.